Next up is our APP supervisor, Katie Fatigante. Our APPs really formed the backbone of our heart team, and it'd be wonderful to hear from Katie as to what this all means when taking care of patients.
Good afternoon. I have been tasked with talking about the role of the heart team and maintaining excellence in our heart valve programs. So this is a shift from a clinical discussion more to a programmatic discussion. As you know, the management of complex cardiovascular disease, specifically valvular heart disease, as we've learned today, has changed drastically over the last decade. To facilitate this complex care, the multidisciplinary heart team is now the cornerstone. The idea of a team-based approach to care has been used in other specialties for a very long time, such as oncology and transplant programs. The multidisciplinary heart team began in Europe with the introduction of percutaneous coronary intervention more than a decade ago. In 2012, the ACC recommended the heart team for patients undergoing CABG. TAVR became FDA approved in 2011. And in 2012, CMS mandated the use of the multidisciplinary heart team for TAVR patients. In 2018, an expert consensus document spoke to the multidisciplinary heart team and included cardiac surgeons, as well as interventional cardiologists and additional providers. However, at the time, there was no guidance on who or how many were to be involved. The most current ACC/AHA guidelines for heart valve disease, which were released in 2020, states as a Class 1 recommendation that all patients with severe valvular heart disease being considered for valve intervention should be evaluated by a multidisciplinary team with either referral to or in consultation with a primary or comprehensive valve center. There are two different levels of valve centers. There's a level 1 valve center, which is the comprehensive valve center, and a level 2 valve center is a primary valve center. The level 1 center is defined by the depth and breadth of procedures that they perform. Essentially, they have the resources to be able to perform all commercially available transcatheter and surgical procedures. Why do we need a heart team? Because patient-centered issues are not easy, nor are they straightforward, and we need to pay meticulous attention to these cases. The heart team provides a balanced appraisal of each specific case. It allows for a complementary approach to patient care by joint and shared decision-making among medical care stakeholders. We can tailor our recommendations to each individual patient. The combined expertise of the heart team allows for optimized decisions with complex patient care issues. As we're learning from our talks today, there are multiple options in how to manage these patients. The heart team allows for an open-minded discussion to determine what the best option is for each patient. The lack of specificity and accurate risk prediction for some patients makes it difficult to make decisions even with appropriate use criteria. Ultimately, by having these discussions and presenting them to the patient, we allow for more patient satisfaction and outcomes. Another great merit of the heart team is shared liability and accountability. Essentially, we ensure that patients are undergoing procedures where the benefits will outweigh the risks. It allows for standardization of preoperative workup because you need a complete workup to have a successful heart team meeting. It increases the opportunities for both interventionalists and cardiac surgeons to advance their skill sets. We know that these complex issues require creativity, and this acts as a place for that discussion. The heart team allows for discussion of new devices and approaches, the burgeoning of scientific information from randomized controlled trials and large registries, and it serves as a place for training for fellowship in an ever-evolving part of cardiology. And lastly, the heart team can provide guidance for the financial and infrastructure decisions for the healthcare system. While there are obvious members of the heart team, such as the cardiac surgeons, interventional and imaging cardiologists, APPs, RNs, there are other key members that we can't forget, such as the scheduling team and administrative staff, quality and data analytics teams, system administration and operations support. These are the team members we would expect a level 1 comprehensive valve program to have. Most beneficial is to identify a clinic valve lead or valve clinic lead that has administrative and clinical oversight. What is the role of the patient in the heart valve team? Obviously at the center of our decision making, but we don't invite them to our heart team meetings. For this reason, heart team is often happens in the clinic. Having a multidisciplinary clinic allows the patient, the valve team, and the shared decision makers to have these discussions openly together. In addition, at our institution, we have weekly scheduled heart team meetings every Monday and Thursdays with both an in-person and team-based option. There is no standardized pathway or model for referral of patients to a heart valve program. I have here an example from our center. Most patients come from a gatekeeper cardiologist who refers the patients to our heart valve center. They are seen by both an interventional cardiologist and cardiac surgeon with the help of an APP at the same time. The decision is made whether the patient should go straight to intervention or if there are questions about the surgical approach, cognitive health, or frailty of the patient, that patient can be discussed in the heart team at a later time with the help of other specialists. While the heart team is important to facilitate patient-centered care, the heart team is also very important for compliance and reporting. In 2012, the TVT registry was designed to support a national surveillance system to assess the characteristics, treatments, and outcomes of patients receiving transcatheter valve therapy. Patient-level data are submitted by participating hospitals to the joint STS and ACC TVT registry. There are key metrics that are required for this registry, such as Kansas City questionnaire, 5-meter gait test, and a 6-minute walk test, which are recorded before the procedure, at 30 days, and 1 year after. The metrics require a team support to obtain and tracked. The purpose of the registry is to measure and assess the quality of care, provide periodic reports and feedback to these participating hospitals, and to foster appropriate research, including post-market studies. On the left or the right side of the screen is just an example of one of the 11 pages that get submitted for the TVT registry, and these exist for our TAVR, TEER, valve-in-valve, TMVR, and tricuspid valve therapies. The heart team ensures excellence in the area of heart valve programs because the data that's collected is objective. There are key metrics for TVT that you can see here, such as 30-day mortality, stroke, life-threatening or major bleed, and AKI. Each individual procedure has additional different endpoints. We get quarterly reports of this tracked patient and site-level data, which is given to us in a whisker plot, as you see on the screen. The final score indicates whether a person is better off going to your hospital versus the average. A more recent development is that TAVR, now with indications for all risk categories, was added to the list of procedures the U.S. News publicly reports. Hospitals are rated on a 3-star system, and the rating system is different than that of the TVT registry. The quality indicators are different for the U.S. News, and as you can see, all of these things are not controlled fully in the operating room. They are not operator dependent. So they are often system dependent, so it requires a strong heart team to ensure we are meeting these metrics. This table further illustrates the differences between the U.S. News and TVT registry. Notable is the data for each is obtained differently. Some is claims-based, while others is internally reported. You'll notice that the U.S. News includes nurse staffing and patient experience. And when it comes to public reporting, we have no choice but for U.S. News. Lastly, the heart team promotes projects that support improvement for all of these metrics. At our institution, we have developed several initiatives around discharge to home, readmission prevention, clinical documentation for risk adjustment to obtain higher DRGs with MCCs. We have structural heart, M&M, and quarterly system-wide meetings. We have quality assurance and process improvement meetings. We have a fully integrated medication optimization clinic, and we have system support for live cases at different conferences such as CRT and TVT. In summary, as you can see from a programmatic standpoint, the heart team plays a crucial role in maintaining excellence at heart valve centers. Ultimately, teamwork really makes the dream work. Thank you.